Welcome everyone to the Special Populations Core 2023 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you so much for joining us for today's presentation. We are very excited to have Dr. Chang of New York University with us to discuss substance use disorder programs in safety net and non-safety net hospitals. Before we jump in, if you have any questions throughout the presentation, please feel free to ask either unmuting or using the chat. We'll also have some time at the end of the presentation for Q&A as well. To get us started, I'm going to turn it over to Jim Lloyd, Research Specialist here at the Center for Health Services Research at Rutgers, to introduce Dr. Chang. So Jim, over to you.
Thanks, Kylie. Dr. Ji-Yun Chang is an assistant professor in the Department of Public Health Policy and Management at the NYU School of Global Public Health. She uses mixed methods research designs and draws from qualitative, quantitative, and geospatial data to demonstrate disparities and highlight barriers faced by safety net providers and underserved patients in accessing equitable care. Dr. Chang is the co-principal investigator of an NIH NIDA-funded study to support the implementation of transitional opioid programs in safety net hospitals. And she is the principal investigator of the AI for Healthy Cities initiative in New York City, which is a multi-city collaboration between the Novartis Foundation, Microsoft AI for Health, and local health officials to reduce cardiovascular health inequities. Dr. Chang received a BA in economics from the University of California at Berkeley, an MS in public policy and management from Carnegie Mellon University, and a PhD in public administration from New York University in 2016. We're excited about this presentation.
Hi, everyone. Can I start sharing my screen? Is that okay?
Yes, absolutely.
Nice to meet you guys. And sorry. And as Kylie noted, I'm very comfortable taking questions throughout the presentation. So if I'm speaking too quickly or if there's any points of clarification, please just feel free to unmute yourself and ask away. All right. So as Kylie noted, I'm presenting some of the work that a team of researchers at NYU and OU have worked on over the past few years, examining the availability of substance use disorder programs across hospitals. This particular presentation will be focused on a paper that we recently published in JAMA Open on comparing the availability of specific SUD programs in safety net versus non-safety net hospitals. Now, I'm sure many of you are familiar with this graph. It shows the total number of drug overdose deaths in the US from 1999 to 2021. And this figure indicates the continued burden of substance use disorders, but also masks a disproportionate impact on underserved communities where the rates of overdose are actually increasing more rapidly. And the harms of substance use disorder, including OUD, extend far beyond overdose itself, leading to stress in the healthcare system, delivery system, and also worsening health disparities. Now, in that context, what we realized was there's also a growing need for hospital-based SUD services. So along with the rapid increase in overdoses, hospitals have experienced a spike in SUD-related encounters. So this figure here, it shows that between 2005 and 14, the national opioid-related inpatient stays have increased 64%, and the rate of opioid-related ED visits have doubled. And according to some estimates, up to 25% of hospitalized patients have an SUD or OUD. So these trends point toward the crucial role that hospitals can play in tackling the opioid and SUD epidemic, because especially because people with a history of injection drug use have high rates of secondary infections, HIV, skin and soft tissue infections. Hospitalizations can serve as a crucial juncture to engage patients who might otherwise not be engaged in ongoing treatment. So what are the ways in which hospitals can support the delivery of SUD services? These are a range of different hospital-based services, including screening patients for SUD or OUD, referring them to treatment, providing medications for opioid use disorder, inpatient services, as well as outpatient services. And a growing body of evidence suggests that these range of services can lead to high treatment engagement as well as provide successful linkages in the long term in community settings. Studied effects of hospital-based addiction care include improved SUD treatment engagement, reduced alcohol and drug use, lowered hospital admissions, and improved provider experiences. And the evidence is strongest for medications for opioid use disorder. As I mentioned, this paper specifically focuses on safety net hospitals. And so, why safety net hospitals in particular? It's because these services, these range of services may be even more critical in safety net hospitals, because by definition, safety net hospitals disproportionately serve historically minoritized communities. They have a disproportionate patient population that are either uninsured or underinsured. And SUD-related admissions are more common in safety net hospitals, and they are also increasing rapidly. A recent paper that from a large urban safety net system, for example, found that between 2008 and 2020, admissions related to SUD increased by 42% and accounted for a third of total admissions. And that same institution found that SUDs accounted for more than 80% of unreimbursed costs. And so, given the location of safety net hospitals in communities where substantial disparities exist, these hospitals are ideal sites to support the local opioid service infrastructure, both through their formal medical services and through partnerships with other community-based organizations. So the key research question here is to examine whether there are differences in the availability of substance use disorder services in safety net versus non-safety net hospitals. There are papers that that have examined this in the past, and prior studies of hospital-based SUD programs point towards multiple barriers to implementing these kind of programs, including financial strain, inadequate personnel, stigma. But most of these papers tended to be qualitative or an in-depth study of one or two health systems. And we saw that there really were no papers examining this nationally. In addition to that primary research question, we also wanted to understand whether these differences vary by hospital ownership type. So decades of research have pointed towards substantial differences in hospital services based on ownership. And so by ownership, we're talking about, is this a nonprofit hospital, for-profit hospital, or a public hospital? So for example, in 2022, there was a health affairs article by Horowitz and Nichols that found that for-profit hospitals are considerably more likely than others to provide services based on profitability. And so given the fact that a lot of these SUD services account for unreimbursed services, we wanted to understand, are there sort of like an interaction between ownership as well as safety net status? So the primary data source for this study is the American Hospital Association annual survey and the AHA survey. And that's an annual census of more than 6,000 US hospitals and healthcare systems. It's a pretty high response rate of about 75% a year. And it's widely used as a source of data on US hospital, like the organizational characteristics and what types of programs they deliver. We supplemented that data set with other data sources to understand the surrounding county in which the hospital is located. We drew that data from the American Community Survey, National Vital Statistics System, and AMFAR's Opioid and Health Indicators database. So specifically, we used 2 questions from the AHA survey to determine the delivery of the 5 hospital-based services I described earlier, which are screening, and consultation in any setting, as well as the medications for opioid use disorder, inpatient services, and outpatient services. And that the last 3 are whether it's delivered by the hospital or by the larger health system. Safety net status and ownership was also drawn from the AHA, and that included the way that we operationalize safety net was whether or not the hospital had Medicaid inpatient days, 1 standard deviation above the mean. This is one common way of defining safety net safety net status. It's not the only way, but it's a pretty common way to operationalize safety net status. We also drew, there's a question on the ownership in AHA, whether the hospital is nonprofit, for-profit, or public. Organizational and county characteristics included the bed count, also from AHA, whether the hospital was a teaching hospital or religiously affiliated. We drew from the ACS for rurality, the percent of white population in the county, percent unemployed, and overdose rates were taken from National Vital Statistics and opioid prescription rates from MFAR. As I noted earlier, the AHA has over 6,000 hospital respondents. That's what we started with, but our final analytic sample included 2,800 hospitals. We removed non-general hospitals because we wanted to understand. So non-general hospitals included, for example, pediatric and specialty hospitals. So they were excluded. We excluded federal hospitals and like the VA system. We excluded 55 hospitals that were located in territories, as well as 1,700 hospitals that did not respond to the 2 SUD questions. For this paper, we did 3 different analyses. First was very simple descriptive statistics. We calculated the mean value of each of the measures that I described earlier, and ran chi-square tests and t-tests to compare unadjusted differences. Next, we estimated 5 separate multi-level logistic regression models that accounted for the clustering of hospitals and states to examine differences in the availability of SUD services based on whether they're safety net versus non-safety net. And finally, we conducted subgroup analysis by estimating the same multi-level logistic regression models by the 3 ownership categories. So here are the descriptive results. As you can see here, hospital participation in OUD programs, it varied widely from a low of 27% for inpatient SUD services and a high of 79% for screening. So it seems like there's more screening and consultation are much more common, but some of the hospital-based services, including inpatient services and MOUD, are less commonly available across all hospitals. You could also see here that the majority of hospitals in our sample were nonprofit, followed by public, and only 9% of our hospitals were for-profit hospitals in our sample. Here are the main results. So multi-level regression results indicate that after controlling for all of these organizational and environmental covariates, safety net hospitals had significantly lower odds of offering all SUD services. And these differences were most pronounced for screening, consultation, and MOUD. I'm going to go back to the previous slide. What's really interesting is if you look at the unadjusted model, it suggests that there are no differences between these hospitals, that it's pretty similar between nonprofit and for-profit hospitals if you're just thinking descriptively. But once you control for things like the organizational side, the hospital size, and other county level characteristics like the burden of different SDOH in the community, that's where the differences emerge. We also see here that in general, overdose rates were positively associated with SUD services, whereas opioid prescription rates were negatively associated with SUD services. So it's moving in the direction as we would expect. Several organizational covariates, including bed size, ownership, were also statistically significant. Not surprisingly, larger hospitals, hospitals with more beds, had higher odds of offering all of the SUD services, whereas public and for-profit hospitals had lower odds of offering SUD services compared to nonprofit hospitals. All right, so these are the results from the subgroup analysis. So to further examine what's going on here, we conducted subgroup analysis by ownership type. So the reference group here across the reference group here, the reference category is non-safety net hospitals. And so what you're seeing here in orange is comparing non-safety net hospitals to safety net non-safety net nonprofit hospitals to safety net nonprofit hospitals, the same for public and for-profit. So the majority of hospitals, as I said, in our sample were nonprofit, about 71%. About a fifth were public hospitals, and about 10% were for-profit hospitals. And as you can see here, what this graph shows you is that there is a difference in the association between safety net status and ownership type, but that difference is only significant for nonprofit hospitals. So with the exception of MOUD, public or for-profit safety net hospitals didn't differ significantly from their non-safety net counterpart when we're only narrowing, comparing safety net versus non-safety net within public or for-profit hospitals. But when you look at nonprofit hospitals, there were significant differences that nonprofit safety net hospitals were much less likely to offer all 5 SUD services compared to their non-safety net counterparts. And nonprofit safety net hospitals were only half as likely to offer screening, consultation, inpatient services, as well as outpatient services compared to their non-safety net nonprofit counterparts. And so these results suggest that while for-profit and public hospitals behave similarly regardless of safety net status, when it comes to SUD service provision, there are distinct differences between nonprofit hospitals that are safety net versus non-safety net. So the key takeaways here is that basically that hospital services may vary. Descriptively, only 1/3 of hospitals offer MOUD services, whereas about 80% are offering screening. Safety net hospitals have a significantly lower odds of offering all 5 SUD services in adjusted models. And public and for-profit hospitals have lower odds of offering all 5 SUD services, and safety net status is only significant for nonprofit hospitals. So taken together, these findings highlight the importance of addressing barriers in expanding access to evidence-based SUD services, especially MOUD in hospitals in general, and nonprofit safety net hospitals in particular. And these findings are particularly concerning given that other research suggests nonprofit hospitals are more likely to lose funding from safety net subsidy programs. They're also more likely to be penalized for patient readmissions and have higher uncompensated care burdens. And so this may limit the ability of nonprofit hospitals to offer additional services to meet the needs of the SUD crisis unraveling across their communities. And additional research is needed to understand the factors underlying these findings. There are growing body of research that kind of point towards, for example, pervasive individual or structural stigma as critical barriers, as well as funding remaining as a widespread challenge. There are several limitations to this study. So we relied on AHA, which is self-reported data. So there is a risk of self-response bias. It also doesn't include a range of other potentially significant variables, such as financial information, as well as non-response bias in the AHA data set. There's also no, as I noted, the definition that we used, which is Medicaid inpatient days. It's one way of categorizing hospitals into safety net versus non-safety net, but there is no one specific operational definition of safety net hospital settings. So that's also a limitation. Also, the binary response to the SUD question in this data set may mask nuances in the scale, scope, and adequacy of these services. Some of the other work that our team has done has tried to address some of these limitations. So for example, in September of this year, a couple months ago, we published a paper comparing definitions of safety net hospitals. So there was a literature review that looked at different definitions, operational definitions of safety net hospitals, and we applied 5 of the commonly used definitions. And we sort of categorized hospitals into those different buckets of safety net versus non-safety net based on these different operational definitions. And so that included the measure that we used, including dish and patient stays. But there are also other ways to define safety net status, including the disproportionate share of hospital funds, Medicaid inpatient discharges, as well as some papers look just purely at ownership. And what we found in this analysis was that depending on the definition you're using, you're capturing different hospitals. And that has implications for funding and healthcare access. So for instance, the University of Florida Jacksonville Health Hospital and Orlando Health Central Hospital shared 4 of the 5 examined characteristics that we looked at, including nonprofit ownership, rurality, large bed size, and location in a non-Medicaid expansion state, but they were excluded from different safety net hospital definitions. So this illustrates that depending on what definition you're using, you might get different results in your analysis. And to address the limitations of relying on the AHA data, which is a self-reported survey, we also have another set of papers that try to look at these questions using a different data set, specifically community health needs assessments and implementation strategies documents. So these are publicly reported documents, self-reported reports that are mandated by the ACA for all tax-exempt hospitals every 3 years. So under the ACA, all nonprofit hospitals, which account for 80% of the hospitals here, they have to report out how they are addressing needs in their community and develop strategies to address those needs. And so we manually coded these implementation strategies and community health needs assessment documents for the presence of a more nuanced set of SUD services, including treatment, primary care services, ED services, harm reduction and risk education strategies, strategies to address social determinants, community coalition building, prescriber guidelines, and policy advocacy. This paper was published. This paper in particular also looked at this idea about disparities based on the racial ethnic makeup of the county. And we found similar results here. It basically found that even after controlling for hospital size and the overdose burden in the community, what we found were significant disparities in the availability of some of these very common SUD services based on the racial makeup of the community. So communities with a higher proportion of African American and Hispanic individuals in the county were less likely to have access to these kind of hospital-based services. So that's the main presentation that I have. As I mentioned, this is collective work across researchers from NYU, myself included, as well as researchers and faculty from Ohio University. Okay, that's it. Thank you.
Thank you so much, Dr. Chang. I will open it up for questions. If anybody has, feel free to unmute or raise your hand, whatever easiest.
Hi, thank you for the presentation. It was really interesting. My question is just about whether you came across in your research any information on whether safety net hospitals, they have like better integration with other providers in the community like FQHCs to link people up with the services that they can't provide themselves in the hospital, and if that might be like a way that they're able to provide it without it being something that they're funding themselves.
Right. So that's a really So we are exploring that actually, but we're doing it through interviews. And so the limitation of the American Hospital Association data set, it's just a survey and it doesn't really dive into the ways in which these providers are um, providing these services. Is it through those partnerships or is it directly? It doesn't actually dive into that nuance. And so we have been interviewing safety net providers in 5 different communities, and they do rely heavily on these partnerships. But there are lots of barriers in getting these partnerships started. So I guess the short question is, this analysis in particular does not dive into whether or not they are more likely to rely on these external resources versus internally. But we are trying to get to that through some of the qualitative interviews that we're doing.
Thank you.
That makes so much sense, the qualitative approach, because you know we've gone through this with New Jersey hospitals. It's the same thing that what they send to AHA. You know, you really have to dig into it to understand what it means.
No, exactly. So we're looking at it, and it's funny because it's 80% are saying that they're all screening, and from experience talking, I mean, so that's the thing is it doesn't. If they screen one patient, they could, I guess, say that they are screening, right? But whether or not
Right.
it really is a common practice and it's sort of integrated into the workflow, that's not captured in that data set. So yes, I agree with you. Qualitative research is necessary in this context.
But then, of course, with the qualitative research, what we found is that then you have to you have to decide whether there's a way to then move towards quantifying what you're seeing in the qualitative relationship. It's one of those things, one of those mixed methods things that you know, we actually found to be quite challenging.
Right,
You know,
right.
you
Going back.
kind of
So
have to go back from scratch and create a, you know, a rational typology and what are the elements of the typology. So I really applaud what you're doing to try to figure that out.
thank you.
Of
I
course, the
really
community
appreciate.
hospital, the nonprofit hospitals have been getting away with murder by the fact that they get these tax advantages for being nonprofit. But then what does it mean to be nonprofit? They want it to mean as little as possible.
Exactly. Actually, one of the data sets we considered using was from the loan report, where they're actually
Right.
trying to examine are nonprofit hospitals actually giving back um, to benefit to the community based on, so to account for the fact that they're not paying taxes. So if you look here so this again is a different study. It uses a different data set, which is the community health needs assessment, which is a required report for nonprofit hospitals under the Affordable Care Act. And one of the categories that we looked for in that reporting was this idea about community coalition, whether or not these hospitals noted in their reporting that, yes, we have a problem of SUD, we have SUD or OUD crisis, and we are working on programs to facilitate collaboration with key stakeholders to address this crisis. We didn't actually dive into whether there were differences between safety net versus non-safety net, but we did find, if you look here, hospitals located in communities with a larger proportion of African American patients, they are less likely to work on this strategy of building sort of these community coalitions. So
Wow.
I think that's one way of trying to like triangulate. So we started with the AHA. We went to speak to stakeholders, but we also looked at sort of publicly available data sources that we could sort of quantify, because this is required for all nonprofit hospitals. So.
Did you get a chance to really dig into this issue with the OUD services, particularly MOUD, of whether you provide services within your own system or allegedly partner with outside providers? Because our sense is that you really kind of have to do the former model if you want to get high levels of engagement for people who come through your system.
That's a really good point. And we did actually, so the paper that we published that the paper that I presented in the appendix, we do sort of dive. So sorry, let me go to the data source. So if you look at the specific data, the question asked for MOUD and inpatient outpatient services, not for screening and consultation, but for those three particular ones, there is actually a distinct, like hospitals are able to distinguish between, okay, are you delivering the services in your hospital, or is it within your health system, or is it with somebody else? What we found was overall, there was really high overlap between hospital and health system. So we just kind of merged the
Right.
two, but
Right.
there were a little bit of a difference between hospitals that say that they are only offering it with sort of partnerships. So this conversation's making me realize maybe we could dive into that a little bit more to figure out the differences in the types of hospitals that are relying primarily on these sort of external partnerships versus internally.
I think it would really be, it would really be beneficial. There's this concept that a lot of people have been talking about of no wrong door. So, the hospital emergency department should, for example, should not be a wrong door. For that matter, being admitted to the hospital for whatever reason and having an OUD thing should not be a wrong door. The interesting thing is that people have been talking about the benefits of integration for all these years, and then meantime the hospitals are integrating, but they're not integrating from a patient-driven perspective. They're integrating from a financial perspective. So they're hiring up all the doctors. I saw some amazing figure the other day about what percentage of American doctors now work directly for United Health as employees. So, but just like they did with the electronic medical records, they don't necessarily think initially about deploying them for true care integration. Like, now that you're part of our system, you need, for example, to be providing the services that are needed by your patients. And we're going to make you a referral, and you're going to accept that referral because that's your job. But they need to be pushed to think that way, because what they think about is, if we acquire more doctors, how does that improve our bottom line?
I agree completely. I think I agree with this idea of the no wrong door, but execution and implementation does matter, right? And so is it a patient-centered approach to delivering these programs versus is it just sort of something that they're taking off a box that they're ticking? That we can't really see from
Right.
this particular data set. Yeah.
Right. I think for all of us, I mean, you're following a mixed methods approach, and we find ourselves constantly justifying the mixed methods approach. And lately, we're getting summary statements like, your project is extremely complicated, and how do we know that you can make all these pieces fit together? Well, we're trying to look on the side of the street where the keys were dropped, and not just look on the side of the street where the light is and where we have the quantitative data. And that method is driven by the needs of the problem, to actually understand the sort of the independent variables of these organizational level variables. What do they actually represent? But then you have to justify yourself, to these funders who want everything to be very sort of cut and dried. And they say, well, you're creating these very complex research designs. Yes, we are, because the problem is complex.
So you'll be happy to, I don't know. We were surprised because when we submitted this, we also thought that as well, because in fact, our first aim was quantitative and the second was qualitative interviews. And our third was a Delphi method. And we were like, this is never going to pass muster. And we did get a lot of criticism, but they did end up funding us. So I guess that there is still room for this type of research to be funded, this sort of mixed methods approach. I think there are still people who appreciate that. So I thank you for that.
Well, the Cherda and Martin's approach to that, I think, was you get the main grant, quantitatively oriented, and then you get a supplement to add the Delphi component.
Right.
That was what they did. Wow, this is really great work, and we really appreciate hearing about it. Let's try one more to make sure that everybody that has a question has a chance to get in and ask the question.
Yeah, I have a question actually, because we are looking at in New Jersey buprenorphine dispensing in emergency departments, and so the distinction between safety net and non-safety net hospitals is important for our work and something we can look at as well. But I'm curious your thoughts on what's relevant to the prescribing of MOUD in emergency departments, specifically what you found in your work, this and other studies. That we should be mindful of moving forward in our own work, looking at buprenorphine dispensing in New Jersey emergency departments.
Right. So we looked at, so as you can see here in terms of the way that this was coded, and again, I'm trying to think back at some of the interviews, whether or not that emerged. By and large, the questions being asked are, do you offer it? And it doesn't actually distinguish by setting, right? So it's not sort of, I think that there is a large body of research that suggests that MOUD in sort of a outpatient setting that's connected to hospitals have very good results in terms of patient engagement. But I don't know if there's enough evidence around, buprenorphine dispensing in ED settings particularly. I don't know if we're at the stage where we've actually looked at, okay, it's not just about whether or not patients are given MOUD at a hospital, largely speaking, versus like which setting in the hospital. But I know that there are lots of researchers who kind of look into that. A collaborator, Noah Crouchsek at NY Langone is looking at that. So there are people who sort of diving specifically into that. So.
Thanks for the reminder about Noah, because Noah does a lot of cool things, but I had actually lost track of the fact that she was doing something specifically on MOUD dispensing in emergency departments.
Well, I think her work is very much about what are the strategies that are being used to link people from emergency settings to other settings. And I think MOUD is one of the strategies that I know she's really interested in exploring. And we've had long conversations about that. But yeah, I feel like I'm, for better or for worse, I'm one step removed because I tend to look at larger national data sets. And we do talk to providers, but I think that there's a strong body of research, her also Honora Englander, like I think that there are lots of researchers that dive in, from at that sort of at the forefront. So yeah.
That's great. Thank you. Yeah, we have for this work, it is Mixed Methods. We'll have the opportunity to speak with providers in emergency departments for those who are high performers in this area and those maybe who are looking to improve. And so, the extra work on the community health assessment, I think, is something important to shaping perspectives for emergency department providers and where they see their role, right, in this intervention and the other factors that influence it. So certainly much to think about as we work on this proposal throughout the next year. So thank you.
Yeah, and I was so surprised at how much data there is in these sort of publicly available reports. Like it's a lot of things are documented there. They've talked to stakeholders, they've surveyed patients, and they report all of that out. And so there's such a wealth of information in these sort of reports that you could sort of dig out. To understand
which ones were coming to your mind in this particular on this particular topic.
So you mean in terms of the community health needs assessments?
Yeah,
so I also, a lot of other work that I do is around cardiovascular health equity and social determinants of health. And so I look back at the community health needs assessment at the largest safety net health system in the US who I partner with, which is Health and Hospitals. And when I started looking into that report, they listed all of the different programs that they're offering related to social determinants and health equity. They surveyed, I think, like 600 patients. They had interviews with 40 people, and it was just a wealth of, like, so much work had gone into these reports that had I not read them, I think I would have missed a lot of sort of like the context of the legwork that these health systems are doing to try to meet the needs of their community. So that's sort of one example. It's not specific to, I guess, this project, but yeah.
So do you are you able to get inside the firewall of H&H and use their own data?
So this is the great thing, is these community health needs assessments and implementation plans are public.
Right.
So yeah, so you could just go on their website and download it for most health systems.
This is all making me very nostalgic, because it takes me back to the very beginning of my career when I was at the Office of Management and Budget, and I was thrown all these immensely complicated documents about the financial arrangements of H&H and their financial arrangements with the voluntaries, because the H&H still relies on the voluntary hospitals for their medical staffing through this very complicated set of affiliation contracts.
Wow,
And as a young, like 22-year-old, I was just sort of blown away by the complexity of it all. But all of that remains, and you're working with John Pamplin on some things, right?
No, I
No?
know, but I have not had a chance to collaborate with him directly.
Okay. I thought I saw it on one of the papers, but I might have misread it because it was very small type. But the potential of using their data, in a really big safety net system like that, there's a lot of potential, but there's even more potential when you can link their data to other data like Medicaid. That was why I was thinking of John with his his access to the New York Medicaid data.
Are you thinking of John Billings?
No, John Billings. I'm sorry. I am thinking. I'm thinking primarily of Charlie Neighbors now that I think about it.
Charlie Neighbors, and I think they worked. Yeah, John Billings was actually one of my dissertation committee advisors. Yes.
Yeah, I think that I think that Charlie Neighbors is stepping into some of John's roles, right?
Yes, and I do collaborate with I haven't collaborated directly with Charlie, but Suji Choi, who's part of his group, we are collaborating on some papers. But yes, it's just a small world, right? Like we're all
John Pamplin works with Charlie on some of those papers, but Charlie is really the guy that sort of is managing the research use of the data set, and he's doing a lot of stuff with the state office of mental health and substance abuse.
Yeah.
So it's just a continuing journey. This goes on for a long time. So I really resonate to the complexity of what you're trying to get your arms around.
Thank you. Very, very much appreciated. A lot of this is hidden work, right? So thank you. And thank you for this venue to be able to sort of share and discuss some of these findings.
Yeah, I think it takes a lot of networking among all of us, because none of the groups is resourced to do everything that is necessary to do with the data. The combination of the intellectual work and just the data work and negotiating the data accesses, which is always so complicated. So I just think it takes a lot of networking among all of us to, to try to put the pieces together. And it's just another way of seeing how complicated this system is for patients. That, how in the world do they negotiate these kind of systems when we study these systems and we can barely understand how all the pieces are interrelated?
Yes, very much agree.
I just want to give a chance for any final questions if anyone has before we sign off. All right. Well,
I think that's great. Well, I won't put people on the spot, although I'll put out fair warnings. People should ask questions.
Well, we are so grateful for your time today, Dr. Chang, and really appreciate you joining. Certainly gives us a lot to think about in our work, and I'm sure everyone here as well. So we really appreciate your time and you sharing your expertise with the NJAX community. And thank you, of course, everyone for joining as well. We really appreciate it. We'll see you at the next seminar, and take care, everyone.
Thank you.
Thank
Thank
you.
you.